Transitioning from individual to group-based delivery, the role of client expectation in the therapeutic process. In the treatment of social anxiety, should Healthcare X switch from one-to-one therapy to group therapy? The research proposal detailed in this presentation aims to help them answer that question. In their 2020 meta-analysis, Barkowski and colleagues looked at 57 studies on group psychotherapy for anxiety disorders. They found that group therapy and individual therapy were essentially equivalent in effectiveness, with a very small effect size of G equal to 0.24. So if both formats are similarly efficacious, can Healthcare X simply switch based on cost-benefit alone? Well, no. Group therapy comes with natural trade-offs. Although it offers peer support, modeling, and validation, the same group dynamics can also create challenges, such as participation reticence or reduced individualization of treatment. Because these limitations stem from clients' personal perceptions of group settings, Healthcare X's real challenge is the transition from one-to-one to group therapy. Will current clients want to transition? Will they believe group therapy can benefit their social anxiety? Since mismatch between client preference and treatment format is associated with higher dropout risk, Healthcare X must consider how clients might react to a shift in delivery. These concerns center on what Constantino et al. Call outcome expectancy, which has a small but reliable positive effect on treatment outcomes. Outcome expectancy is typically measured using validated self-report scales, such as the Credibility Expectancy Questionnaire, which we'll use in our own study. Furthermore, recent studies have shown that expectancy can be deliberately influenced. Seewald and Reif, for example, demonstrated that therapist behavior can reduce negative expectations, and Braun-Koch et al. Showed that brief educational videos can improve expectations among skeptical patients. However, neither of these studies examine outcome expectancy in the specific context of transitioning from individual to group treatment. Our research question, therefore, is: does an educational expectancy-enhancing intervention increase expectations of the effectiveness of group therapy among clients currently receiving individual therapy? We hypothesize that clients who receive the expectancy-enhancing intervention will report higher outcome expectancy for group therapy than clients who receive a neutral intervention. So, methods. Our participants will be adults who have a diagnosis of social anxiety disorder and receive one-to-one treatment for it. In addition, participants will be required to have no experience of group therapy. Participants will be recruited from organizations similar to Healthcare X, but not from within Healthcare X itself, and the study will also be advertised to students and staff at the University of Stirling. A sample of 40 to 60 participants will be appropriate because expectancy-enhancing interventions, such as Braun-Koch et al. Study, found medium-sized effects, and this sample size provides adequate power to detect effects of that size. A between-subjects experimental design will be used, and the data gathering will be completed online. Participants will be randomly assigned to one of two groups. The first group will receive a positively framed educational intervention about group therapy in video form, and the second group will receive a video of the same length, but it'll be neutral in tone. The independent variable is intervention type, and the dependent variable is outcome expectancy for group therapy, measured immediately after the intervention. And this brings us to materials and procedure. We'll use the Credibility Expectancy Questionnaire to measure outcome expectancy. The video shown to participants will be produced by the research team and will both last around 5 minutes. The educational expectancy enhancing video will provide an explanation of how Healthcare X will deliver group-based therapy for social anxiety, and it will include evidence-based information highlighting the clinical effectiveness of group therapy. The content will be positively framed and designed to enhance outcome expectancy, while avoiding exaggeration or misleading claims. The control group will view a video of the same length containing only the neutral descriptive information about how Healthcare X would structure group therapy, without any expectancy-enhancing content. For analysis, since we only have two conditions, an independent samples t-test will compare outcome expectancy scores between the intervention and control groups. Broadly speaking, this experiment should be moderately feasible to conduct. We predict that filming and editing the videos will take between 3 to 5 days to complete. So this study does not determine whether Healthcare X should switch to group delivery, but rather provides a tool to help them make that decision in an informed, client-centered way. Because participants in our study would be randomly assigned to one of two conditions, any observed difference in outcome expectancy scores can be attributed to the more positive video. A higher mean expectancy score in the intervention group, in the educational group rather, would support the hypothesis that brief structured information can modify expectations about group therapy specifically. Although the study does not involve an actual transition to group therapy, it would provide preliminary evidence on whether outcome expectancy in the context of considering a transition can be influenced by positive educational information. This is currently unknown, as existing expectancy research focuses on general therapy attitudes rather than transitions between delivery formats. If our hypothesis is supported by the data, then it would show that expectations about group therapy can be modified in patients who currently receive one-to-one therapy. The importance of knowing this lies in the implication that if expectations, which we already know have an effect on treatment outcomes, can be boosted, then they are also susceptible to being diminished. This would highlight how potentially precarious a transition period could be for clients, and would give Healthcare X justification for actively managing the transition using educational interventions to maintain and enhance expectancy and reduce the likelihood of disengagement during the shift to group delivery. Broadly speaking, the anticipated findings would highlight outcome expectancy as an important psychological mechanism that healthcare services should consider when altering treatment delivery. With this knowledge, services could support clients' engagement proactively rather than reactively, ensuring that expectations are addressed before changes occur rather than after difficulties arise. For organizations like Healthcare X, this would mean that if a shift from individual to group therapy were being considered, steps could be taken to stabilize and strengthen client expectations prior to implementation. The study would therefore offer a practical framework for managing treatment format transitions, one that could be applied beyond social anxiety and beyond Healthcare X to other services undergoing similar redesigns. Thank you.